This is the last talk in the Wagner Prize competition sessions. And we have with us today Summer Gentry from the United States Naval Academy and Dory Sega from Johns Hopkins University Department of Surgery.
Thank you so much. Thank you to the Wagner Prize Committee for the opportunity to present this. I'm happy to be representing the U.S. Naval Academy, as did Dan Wagner. And in a few minutes, I'm going to present Dory's transplant surgeon, and he'll tell us a little bit about the existence of geographic disparities in access to liver transplant around the country and why it's been so difficult to address this problem. And then I'll talk about the integer program, the redistricting model that I designed, and the detailed clinical simulation that helped us prove that redistricting would both save lives and mitigate those geographic disparities that are so distressing. And then after that, I'll have Dory talk about some of the remarkable successes that we've had in terms of making transplant policy with this redistricting concept. So, Dory?
I was told that this is as gory as I can get. So this is a liver. And there are about 16,000 people waiting on a long list for one of these. So I want to start by telling you about an email I got a few years ago. It's actually an email I get on quite a regular basis. So a young man from San Francisco emailed me in desperate need of a liver. His significant other tried to be a living donor, but was not medically eligible. He was getting sicker day by day and was desperate for any advice I could give him about the deceased donor waiting list. I told him to move. Why did I tell him to move? So let's step back for a second and talk about liver allocation in the United States. So the U.S. is divided into 57 donor service areas, DSAs, and this is the first unit of allocation. So when an organ becomes available in the DSA, it goes to the person listed in that DSA who has the highest MELD, or the model of end-stage liver disease. MELD predicts your probability of death in the next 90 days. So basically, we're allocating a liver to the person who's currently most likely to die without that liver. Unfortunately, where you live also determines if you live. So as you can see, the higher your MELD score, so that's here on the x-axis, the higher chance you have of getting a transplant in the next 90 days. That's here on the y-axis. But the problem is the range is very wide, and this is the range according to donor service area. So the range depends on where you live. So for example, if your MELD score is in the 38 to 39 range, you're very sick and you need a transplant desperately. If you live in some areas in this country, you have an 18% chance of getting transplanted in the next 90 days. If you live in other areas, you have an 86% chance of getting transplanted in the next 90 days. And this is problematic, obviously, because it translates directly to your probability of dying on the waiting list. So for those same desperate people with the MELD of 38 to 39, if you live in some place in this country, you have a 14% chance of dying in the next 90 days. If you live in another place, you have an 82% chance of dying. And the whole range spans according to the country. These geographic disparities are in clear violation of Congress's decree in 1998 that neither place of residence nor place of listing shall be a major determinant of access to a transplant. Now, I told you about DSAs. DSAs are nice because they allow a handful of hospitals to work closely together to improve organ donation. But it turns out that the only way to make allocation more fair is to share across larger areas where supply and demand can be better balanced. Now, we don't want those areas to be too large, like the entire country, because we worry about cold ischemia time. And there's sort of a threshold for cold ischemia time. We don't want the organ to be out of the body for too long because then the outcomes can start to deteriorate. So you need something bigger than a DSA, smaller than the entire nation. Interestingly, the second unit of allocation in the U.S. is grouping the DSAs into 11 regions. Now, the transplant community considered sharing across these regions instead of the smaller DSAs, but unfortunately the regions are this sort of historical artifact, were never designed for any specific person and purpose, and actually were certainly never designed for fair allocation. And it turns out that if you model sharing across the current regions, it actually makes the current geographic disparities worse, not better than the local system. So in the late 90s, the transplant community tried to redraw the map with an eye to balancing supply and demand. The problem was with every proposal, sort of in ad hoc proposals, there were clearly winners and there were losers, and this caused the famous liver wars of the 1990s. These wars shifted the focus from the patient to the transplant center, and they escalated to lawyers and lobbyists and media and other tactics that aren't sort of common or suitable for the medical field. And the result was an impasse that our community has not addressed for 15 years. In other words, 15 years of violating the congressional mandate for geographic equity, 15 years of patients like the one who emailed me moving from California to the southeast to save themselves from dying on a growing waiting list. And that's where things stood when Summer and I started our collaboration.
So I think for the operations research folks in the audience, we have immediately already jumped to, well, this is a redistricting problem. This is a traditional problem within operations research. There's literature going back to the 1950s, and we've all seen what these models look like for designing voting districts, for designing school districts. So I think what you'll see in a few moments when I talk about the equations that go into this integer program is that there aren't any sort of mathematical surprises, but actually our real contribution here is in working with the transplant community to formulate a model that is utterly transparent and understandable to them and relevant to the questions they're really asking about designing liver allocation systems, and that can answer their questions in a detailed way so that they can actually generate buy-in for changing the way that livers are allocated. So we're going to partition the DSAs into new districts using an integer program that we solve with OPL-Cplex. And after that step, we'll test those district maps with a discrete event simulator called the Liver Simulated Allocation Model. And once we group the DSAs, we're going to preserve the DSA boundaries because those are organizations that have sort of generated these areas for a long time. But we're going to group the DSAs differently into sharing districts, making the assumption that redistricting will shift the first unit of allocation to be the district. The liver will go to the sickest person anywhere in the district, the person with the highest MELD score. It's not that no one else was interested in redistricting or looking at improving liver allocation. The Institute of Medicine was actually asked to address this problem in 1999, and all they could say was that they believed the allocation units should contain 9 million people. But they weren't able to guide the choice of which 9 million people to balance the supply and the demand in the areas that they would create. There's work by Kong et al. They maximized a pure efficiency metric that does something like balance the loss in viability of an organ when it has to go very far away against maybe some idea that within a very small region you might not be able to find any candidate who is a compatible match for a certain liver that's available, and that then it would be wasted. This actually doesn't match biologically. Liver transplants don't require close compatibility matching. There is no such thing as a liver allograft that is incompatible with every candidate in a certain area. And so that notion is sort of, it does apply for other organs, maybe for kidneys and bone marrow, but that's what they did. And there's also work by Stahl and Demirci that maximized a combined efficiency and equity metric. And the equity metric there was maximizing the intra-district transplant rate, maximizing the minimum transplant rate, so trying to make the transplant rates similar. But that neglected completely the MELD score prioritization of candidates within those districts. So all candidates have the same need for an organ. So all of these things are kind of make these models hard to apply or hard to show how they're relevant to transplant. And I think also these models really overweighted and overstated the problem or the viability loss in transporting an organ. So as you'll see, we developed a much more detailed model of the transport system to show when that would and wouldn't be a problem. So our redistricting model minimizes the number of misdirected organs, where we define a misdirected organ as the organ that in a purely geography-free national system where we can just teleport the liver to the very sickest candidate anywhere in the country, and they always accept it. We offer those organs to the sickest person down to the least sick where the number of livers runs out, and we say that's the number of organs that should have gone to this district, and we minimize the difference between that and the number that we do actually have available for a district. So this is, you see, a pure equity objective. The only thing we are maximizing is the balance between supply and demand, and so, but because MELD predicts waiting list death, there really shouldn't be any conflict. There's no trade-off between equity and efficiency in this model, because if we define efficiency as reducing waiting list deaths, which is the explicit goal of the allocation system, then getting every liver to the very sickest candidate that it could be gotten to is going to reduce waiting list deaths. So the strength of what we've done is in this interaction with the transplant community, and through iterating over a couple of years of meetings with the OPTN liver committee. The OPTN is the Organ Procurement and Transplantation Network. They oversee allocation policy. They came down to these design constraints to tell us about that. The districts should be contiguous, and the star is, well, the DSAs aren't contiguous. So you may see a few baubles in the maps that are finished, but to the greatest extent contiguous. The number of districts should be at least 4 and no more than 8. Now we have 11 regions, so they are pushing towards broader sharing areas. Maximum median transplant volume weighted transport time between DSAs being 3 hours. So that transplant volume weighted, that means if you have a transplant center that does a very large number of transplants, the distance from donor hospitals to that transplant center counts more in calculating those averages. And the last constraint is very interesting. The minimum number of transplant centers per district has to be 6. And this constraint was definitely not in our original formulation. It turned out that we showed up at the liver committee meeting and showed some preliminary district maps, and someone said, I don't like that district. That's not acceptable. Okay, why? Well, I know that there are only 2 transplant centers in that area, and it turns out that transplant centers and transplant surgeons are very competitive. And so the competition between centers drives the use of these more marginal organs, makes more organs less likely to be discarded because the transplant centers want to be able to use their livers. And so they wanted to make sure they drove that kind of competition that could get more and more livers utilized. Notice that all of these constraints are they have natural units. Every number in my model has a natural unit, is interpretable by a transplant physician. So here's the model. We have script I and script K basically are just the set of districts, the set of DSAs. And I have just 2 sets of decision variables. The WIKs are binary. 1 if DSA I is selected to be in the district with the center at DSA K, and 0 if not. And then the YKs keep track of which DSAs K are district centers. So we're going to select a subset of the DSAs to be the district centers, and that's a decision within the optimization model. The other things are parameters. So we have number of transplant centers, number of donors, the number of donors that should go to a certain area, the volume-weighted distance and transport time both come into this model. So here's our objective. We minimize the number of misdirected livers. So inside the absolute value signs, we have the number of misdirected livers for District K, and we add that up over all of the districts. Then every DSA is assigned to 1 district. And if DSA K is assigned as a district center, then I want YK to be 1. The number of districts is n. Now, we adjusted that n to offer the committee different alternatives, a 4-district map, a 6-district map, an 8-district map. And the second constraint is that minimum number of transplant centers per district must be at least H bar that I was describing. The maximum transport time from each district to the district center constraint. And finally, this is really the compactness or contiguity constraint. These are from Daskin. The alpha ij's are 1 if DSA I is farther away from DSA K than it is from DSA J. So this says, now if YJ is 1, then that means that J is a district center. So that right-hand side is going to be 0, and that's going to say that I have to make sure that no DSA I is assigned to a different district center if it's farther away. So that basically every DSA is assigned to its nearest center. So here's an example of an 8-district map that we designed. Now, these are not super computationally challenging. They do take an hour or two to run on a standard PC, but we didn't run into any barriers beyond that. 4-district map that we designed. And we wanted to test these in a much richer discrete event simulation model of allocation, because the optimization model is taking this dynamic process where people get sicker and then they get healthier and they drop out of the waiting list and they die, and boiling it down to there are these many patients and these many organs, and that doesn't happen. Those don't happen at the same time. So we need to incorporate things like people might decline an offer for a liver, particularly if they think that that's a marginal liver, or the livers are not identical, the MELDs are not fixed. So to capture all of that, we go to the liver simulated allocation model that has a patient-level data. They know the liver simulated allocation model knows the patient's age, MELD score, diagnosis, the donor's cause of death, etc. So here's a schematic of the liver simulated allocation model. Here you see the patient's MELD status being updated. So we changed, people get sicker, people get better. We have here patients arriving and organs arriving, and the allocation being determined by whatever redistricted plan we're testing. It's very important that we also have the accept decline module, that some liver offers are declined, but then you offer the liver to someone else. And that people on the waiting list, if they get sick enough, they may die or be removed from the waiting list for being too sick to transplant. And all of these are decided at an individual patient level, comorbidities, etc. Now, this model existed before we got involved in this work, but we had to expand it in lots of ways. We went from a fixed patient set to a resampling scheme that allowed us to both get confidence intervals on our estimates and also run this simulation for much longer, over a 5-year period. We also added to it a model for transport time, because I've described that transporting the organs for a very long time was a barrier, and also a cost model, because people feared that redistricting would just cost too much. So we added those things and integrated them with the liver simulated allocation model. So it turns out that transport distance is only very weakly correlated with the delays, with the cold ischemia time delay between recovering the organ and transplanting it. The only part of that delay that's attributable to allocation is how long it takes to get from the donor hospital to the transplant center, and that's usually less than 20% of the delay. So we geolocated the transplant centers' addresses and the airports that they use for these charter flights to get the organs where they're going. We used Google driving directions to get drive times. We also have flight times and the driving to the airports. And then we have a decision module in there that says, will this organ be driven or flown to its destination? We also created a detailed cost model, because those charter aircrafts are expensive and the cost depends on how far you have to fly. We wanted to also consider the costs of taking care of those patients, because the high MELD patients are very sick and they cost a lot to take care of, to maintain in that state. They get readmitted to the hospital, they're in the intensive care unit, and so there may be savings to be reaped from getting those high MELD patients transplanted earlier so that we are not having them stay on the waiting list, accumulating all those costs. So here are some of the impacts we predicted. On the leftmost column, you see that this is the optimization objective this is a purely local system, regional sharing in the existing 11 regions, fully national, and then a 4 or 8 district redistricted system. And you can see in the standard deviation of median MELD, that is, how much does the median MELD at transplant differ from DSA to DSA? So this is recapturing the dynamic nature of what's going on in liver allocation. So this is, I would say, a more transplant-friendly metric of geographic disparity in terms that people are used to thinking of, well, what does my MELD score have to get to before I might be able to get a liver offer? And you can see that, as Dory alluded to, the local allocation that we're doing now is actually better. Regional allocation within our not well-designed 11 regions would make geographic disparities worse, paradoxically. And you can also see that in the national system, this 1.66 is sort of like a lower bound of achievable reduction in disparity. So the 4 and 8 district systems have much less of this disparity between how people are treated based on their zip code. And remember that, again, I optimized a pure equity metric, but I said I think this will do well on efficiency also. So on the far right, you have the net waitlist deaths. Waitlist deaths prevented by going to a redistricted system. You see hundreds of lives saved over 5 years using these systems. Here's another way to look at disparity. All of the pink areas are places where people can get transplanted now at very low MELDs. And all of the red areas are places where people can have to be very, very sick to get a liver offer. So bright red is extreme shortage and pink is extreme surplus. So you can see why Dory would have suggested that a patient move from California to the southeast. And the patients that are moving now, of course, are the ones with resources, the ones with savvy, and who have the education to go out and find this information for themselves. And the other ones, unfortunately, are dying at a higher rate than they should. And here's the same map for fully regional sharing in our existing 11 regions that don't do a very good job of reducing disparity. You can see things don't really get any better. In a few places, things get worse. But with an 8-district redistricted system, nearly every place in the country, people would have equivalent access to a liver transplant. Now, you do see California staying in red. California is geographically disadvantaged. It's just very far away from places that have a sufficient supply of donors. And with the transport time constraints that we had, we really weren't able to find maps that resolved the problem in California. The alternative would be to go to relaxing the distance constraints, but essentially we designed to the liver committee's specifications. But this shows the same thing, a big reduction in disparity for a 4-district redistricting model. And the transportation time, which everyone had been suggesting was a big reason not to go to redistricting, turns out to be much ado about nothing, because the current system has a median of 1.5 hours of transport time, and we predicted that that would only increase about half an hour, even in the most extreme redistricting scenario at median. And so the half an hour, that's really not much when most livers are enduring 6, 7, etc. hours of cold ischemia time. It's just not significant, even though the distance that the livers went increases a lot, mostly because instead of driving, we would have to fly a lot of those livers. Well, that would cost something. It would cost about $65 million more to fly those organs to where they're actually needed, rather than using them locally where they can be driven. But that saves an amazing amount of money in caring for very high MELD patients who are waiting on the list, who are being rehospitalized, and in using up a lot of healthcare resources. So it turns out that on net, redistricting is one of those rare medical interventions that is actually cost-saving. Redistricting would save something more than $300 million to the medical system. And now I'm going to have Dory tell you about how the transplant community reacted to some of these findings.
So the first presentation of this, Summer gave at a plenary session to several thousand transplanters at the American Transplant Congress in May 2011. This got the attention of a lot of the groups involved in transplant policy, including the Organ Procurement and Transplantation Network, the OPTN, which Summer told you about, which is actually a government agency entirely responsible for all organ allocation in this country. So if they pass a policy, that's what happens nationally. They work under HRSA, and they're the final say in all national allocation. So they got interested in this, and this inspired them to resolve several things at their board about a year later. And a year is actually a very short timeline for OPTN to resolve anything. If you can draw the analogy to Congress, you might get a sense of it. One of the things that they resolved was that the existing geographic disparity in allocation of organs for transplant is unnecessarily high, or unacceptably high. This was the first time that this sort of 500-pound gorilla was ever actually addressed in writing since the 1998 congressional mandate. The board directed the organ-specific committees to define the metric of fairness and any constraints for each organ system and gave them a timeline for doing so. And the liver committee sort of led this effort because this is the area that we were working on, and the area sort of most closely tied to deaths versus getting liver offers. The board also requested that optimized systems utilizing overlapping versus non-overlapping boundaries be compared, including using or disregarding current DSA, region boundaries, and allocation, etc. Although clearly the initial bent was to maintaining the DSA structure for the advantages that I told you about, that the DSAs are these closely knit communities working together to improve organ allocation. Immediately, the Liver Committee took this up and made this their top priority for 2013 to 2014. So here you see what they called liver distribution redesign modeling. That's basically, they didn't want to use the word gerrymandering. But essentially, they decided to work for 2 full years on this. And this culminated in April of 2014 in a unanimous vote by the Liver Committee to take the proposed plans for public comment. And basically that's the last step before something becomes policy. Is you write a policy document, you get public comment, and then you give it to the OPTN board to vote on. And this is a quote from David Mulligan, who's the chair of the OPTN Liver Committee, giving you a sense of what this meant to the liver community. So in short, the unanimous vote taken on April 1st that sent 2 optimized redistricting plans forward for public comment was unprecedented. I could not have imagined that every single member of the Liver Committee, including members representing transplant centers that are expected to do fewer transplants as a result of redistricting, would vote in favor. And why is that? It's because they weren't voting on an ad hoc map. Because obviously if they're looking at a map, they'll say, well, my center doesn't benefit from this, and that's hard to vote for. But they were voting on principles that fed into the optimization. And so they were voting that it is important to reduce geographic disparities. It is important to have a certain number of districts, to have a certain number of centers within those districts. If you agree on the inputs, then the optimization is this beautiful link and this sort of inextricable link that tells you, with these priorities that you've chosen, this is the way the map should look. In September of this year, after that Liver Committee vote, the OPTN held a public forum. It was the largest public forum that the OPTN had ever held, and basically almost every single member of the Liver Committee was either there in person or was there online participating, because this is a change that would obviously have huge impacts on the transplant community. And what we've done, OPTN put together a nice video sort of summarizing this forum. We have a video clip of that, and so I think why don't you play that summary? Sure. I'm going to aim the mic at the speaker here so you get that on the video.
It was the largest public forum in OPTN UNOS history. 240 people gathered in person and another 280 online for a day-long public forum on redesigning liver distribution. Attendees represented transplant centers, organ procurement organizations, and the public from across the country.
The reason this is such an important problem is because we have large geographic disparities in this country.
The Liver and Intestinal Organ Transplantation Committee sponsored the forum with one goal: gathering input to reduce geographic disparity in liver transplant. Dr. David Mulligan explained the Liver Committee's approach and recent concept document that suggests redistricting could save 550 lives over 5 years.
We decide the number of districts should be at least 4, but no more than 8 districts, and that the minimum number of transplant centers per district should be 6.
Dr. Mulligan led a panel of experts, including Dr. Rio Hiroshi, Dr. Jack Lake, Dr. Summer Gentry, and Dr. Dori Segev, which detailed metrics and a variety of mathematical solutions for reducing geographic disparity, including new districts and concentric circle designs.
And the concentric circle maps displayed a worse trade-off between the transport impacts and the reduction in geographic disparity. So
the panel, during an hour-long morning discussion, fielded nearly 24 questions on distribution concepts, metrics, costs, and results.
So as you can see, we're very hopeful that redistricting allocation will save lives. I don't want to go from the beginning. I want to go from the third side. We'll both save hundreds of lives and reduce these sort of untenable geographic disparities. But I wanted to go a little bit further and sort of describe what I think are the lessons from this project for implementing OR solutions in healthcare, which I think has been one of the areas a little bit resistant to OR-type modeling. One of them is that your optimization models should always be transparent and not have betas and alphas floating around that don't have units that are sort of, well, you set this somewhere between 0 and 1. You can enable decision makers with optimization to focus on what are the goals of my system rather than looking at detailed implementation level questions and where they can critique this ad hoc policy. And when we did the optimization, we made things extremely simple as they had to be for us to solve the redistricting model, but then we used simulation to bring that realistic clinical detail back in so that you could get buy-in by offering these detailed results to clinicians. And the last thing I think is that we developed credibility through being engaged with the transplant community over many years. Our first project in optimization in transplant was optimizing kidney exchange. We wrote the first paper on maximum edge weight matching in grafts for kidney exchange in 2005. Many papers followed, and even an act of Congress explicitly legalizing kidney exchange, which might not have happened if we hadn't been able to provide simulation results showing how many kidneys might become available through this. And we had been working with the OPTN through all of those years on creating its national kidney registry. We donated our software to that effort, etc. So that is really what led the Liver Committee to be able to invest in us, to spend all of this time. And we want to thank all the physicians and the representatives on that committee for everything that they did to help shape these results. And I'll say, while I'm saying thank you to my other colleagues at the Scientific Registry for Transplant Recipients and to the Epidemiology Research Group in Organ Transplantation, particularly Eric Chow, Alan Massey, and Corey Wycliffe. Thank you.